I'm here to talk about perioperative management of opioid antagonists. Maybe a little bit of an odd talk for a pain conference, but I get a lot of questions about this, not through formal consults, but on my cell phone from my anesthesia colleagues who are like, you prescribe opioid antagonists, right, in the pain clinic? I'm like, yeah. So then they're like, well, perfect. Got a person who can answer this question for me. And I think what I want to talk about this is that there isn't a lot of literature on this. And I think we're going to see more and more use of opioid antagonists in pain and in other fields. And so it's going to question, I think, that's going to come up within our community. And the way I approach this is how I think a lot of anesthesiologists approach perioperative questions, but also I think how interventional pain physicians approach. And one of the classic examples is around anticoagulation. What do you do with the patient who's on anticoagulation? That there's not a single answer, right? Patient who's on warfarin, you're going to think about like what procedure are they having? What is the risk? What's the time course? And based on that, you're going to think about, well, can I reverse it if I need to? Can I bridge them to a safer therapy until I need to do the procedure? Or do we really need to hold or cancel the procedure or rethink what we're doing for this patient? And that there's not a one size fits all answer to these questions. And I think that that determination of risk, estimating the risk of a bad outcome, then determining timing and actual pharmacological therapy is an approach that I would apply to opioid antagonists, but I feel like people are not looking for that answer. People think there's a one size fits all answer, but I think the model of how other perioperative questions or peri-procedural questions have been answered for pharmacological agents is probably the approach we need to take. And this really comes to naltrexone because naltrexone is our opioid antagonist agent that's really PO bioavailable. Naloxone, as we know, is combined with buprenorphine for Suboxone, but it's only like about 2%. Doesn't really have much of a use or interference with opioid therapy in the perioperative space where we want to manage patients with acute pain using opioids. The FDA approved products for naltrexone as of last month are Contrave, which is for weight loss approved. So it's a bupropion and naltrexone combination product. It's 90 milligrams of bupropion and 8 milligrams of naltrexone, but at the titration, patients eventually on 32 milligrams of naltrexone a day. So a significant amount, along with Vivitrol, which is a 380 milligram IM extended release once a month suspension for alcohol use disorder and opioid use disorder. And then there's also PO naltrexone at 50 milligrams, which is FDA approved for both alcohol use disorder as well as opioid use disorder. And then off-label, I think a lot of us are starting to use naltrexone for all sorts of issues, including neuroinflammatory conditions, autoimmune conditions, as well as conditions such as fibromyalgia, with some of the research that has come out saying that there might be a subset of patients who are responders to this. And there's been interest in ultra low dosing, moderate dosing. There's all sorts of dosings of naltrexone. And this is where I think it gets really complicated with the off-label use and why I think it's important, because we start patients, and I think a lot of pain physicians are starting patients on naltrexone. But what happens when they go to surgery? What happens when they go to an elective procedure or an emergent setting in the ER and they need to get pain control using opioids? There are other opioid antagonists like naloxone and the mixed agonist antagonists, but I won't be talking about them. We're going to really be focusing on naltrexone for this. And so what does the current data say? There's very little. When I did a literature review, it's essentially all either single case reports or expert opinions, extrapolating based on what we think the pharmacology is or what we think we should be doing for these patients, unfortunately. So there's not a lot of data or a lot of practical experience in regards to these cases. But I realized I was like, well, there must be surgeries and procedures happening for these patients. And what was really surprising was I actually saw this presentation a couple of years ago that a lot of providers are really uncomfortable with how to manage opioid addiction therapy. And one of the large pieces of that is not just opioid maintenance therapy, but opioid antagonist therapy. So combining the fact that there's very little data and literature available with the fact that it seems like many people are uncomfortable with how do you manage these patients, that we should probably do a better job of beginning to address these questions before they become problems, given the fact that it seems like there are more pipeline uses for opioid antagonists coming down. And so what we did was at Stanford, I looked at all the patients who had been on an opioid antagonist therapy over essentially a 7-year period, and saw what had been done for them. And so we had about 100 patients on Contrave, which is about 32 milligrams of naltrexone. We had about 100 patients were on low dose naltrexone. We defined that as less than 10 milligrams a day. We had about 36 patients who were on greater than 10 milligrams of naltrexone a day. We only had about 6 patients who were on the extended release 380 milligram Vivitrol IM suspension. And what we found was that there was a lot of variability in how these patients were managed, which also I think reflects the fact that there's not a lot of guidance, there's not literature to figure out what to do. And I think what was most interesting was that for a majority of patients, cessation prior to surgery was not even discussed. Like there was not really quite a plan of what to do. People were sort of like, oh, this is just a drug, we'll just sort of continue it. And when you look at the literature review, for contrary, there's a single case study that's been published. For low-dose naltrexone, there was nothing that I found in the literature about how to manage these patients. For patients on naltrexone, there was really just like, there was essentially no information available. There were sort of expert opinions. And that really came actually for the extended release naltrexone, where the guidelines were based on case studies or theoretical data. One of the interesting things about using theoretical data for naltrexone is that naltrexone's half-life is actually very short. But when they did the initial studies in the 80s looking at carfentanil and naltrexone and how long to get opioid blockade, they actually found it lasted for 72 to 108 hours, which is much longer than its elimination half-life. And it sort of reflects the fact that we don't actually know fully the pharmacology of this agent. But practically speaking, it seems like discontinuing 3 days prior to surgery is probably one of the best course for patients who are on 50 milligrams or even on the 32 milligrams. That same study that was done in 1988 looking at carfentanil and opioid blockade with naltrexone found that at 50 milligrams, you were getting 100% opioid receptor blockade for 25 milligrams of heroin up to 48 hours, which really led to the conclusion that we could probably get away with less than 50 milligrams for true opioid blockade. And so add doses such as 32 milligrams, 40 milligrams, 50 milligrams, we're going to be talking about complete opioid receptor blockade for 48, 72 hours, which can be really challenging when a patient is on it for alcohol use disorder and are essentially an opioid naive patient, and you want to give them very low dose opioid therapy post-procedure. They're going to really struggle with getting them to have a response for it. With low-dose naltrexone, it seems like these patients are not going to have a lot of interference. At less than 10 milligrams, you've got enough opioid receptor openings to agonize them, particularly with a full agonist. And so sort of understanding where that sort of guideline or that line is for management is actually really important. And we have some patients, at least in our practice off-label, where we're using low-dose naltrexone, where we actually get them up to 16, 20 milligrams because they keep on responding or responders to higher and higher doses for all sorts of central pain states or nosoplastic pain states. Extended release naltrexone offers a really challenging scenario where patients are on it oftentimes for heroin addiction or for alcohol use disorder, where you have essentially complete blockade for at least 2 weeks, and you start seeing some receptor openings at 3 and really at the 4-week mark. But the challenge, I think, particularly with opioid use disorder, is that we have to think about the fact that we're taking a patient with an opioid use disorder, oftentimes with a concomitant chronic pain disorder, throwing them into an acutely stressful situation with surgery, and then we're giving them opioid therapy. So we're giving them the agent that they have a use disorder with, and we're taking away their treatment for their opioid use disorder, right? So it's a very complex situation. And I think one of the interesting things with extended release naltrexone that we've seen with our addiction group that I've been sort of working with is that they've started to bridge their patients with oral naltrexone. Whereas you need to dose the extended release naltrexone every month, if you need to plan a surgery, then you bridge them to 3 days prior to surgery with oral naltrexone, and then you can get them started back on oral naltrexone very quickly after surgery, as soon as they're off of their opioid agonist therapy, and then you can get them back onto a cycle of extended release naltrexone. And the idea really came from sort of the warfarin management and sort of peri-procedural space, like we can use a bridge for these patients. And it can also be important, as we've discussed with our addiction colleagues, psychologically for patients to know that they're continuing a therapy, right? It's not just as simple as, yes, they're on their therapy, but a lot of patients rely psychologically on the fact that I am on this therapy that has worked for me, for my alcohol use disorder, for my opioid use disorder. And so even though physiologically or pharmacologically, there may not be a use really to bridge patients for a week in alcohol use disorder because the changes from opioid antagonist therapy and alcohol use disorder are really chronic, it can be really important psychologically for patients to know that they're continuing on their therapy for their use disorder, particularly around a stressful situation such as surgery or a procedure. And so moving forward, I think there's a lot more that needs to be done in this space, specifically given that there's actually increasing interest in the use of opioid antagonist therapy for various conditions. And I think this is a problem that we're just starting to see, and I think we're going to see more and more of it. And I think there needs to be more discussion with the stakeholders who are prescribing these medications, because it is truly multidisciplinary. We're prescribing it in rheumatology, GI, addiction therapy, psychiatry, pain medicine. And we need to really look at larger data sets and discover and create some policy around this. We're working currently to develop an institutional policy at Stanford, looking at how we should manage these patients. But I think this is going to be a problem that's going to be starting to come about in the community and many other centers. And so I think it's going to really take more of a community, sort of a national effort to figure out how should we be managing these agents and to have guidelines for new agents as they start coming to the market and for use.